Asking me to present this lecture, and my apologies for not being able to present it in person. I wish to thank the chairpersons and the Congress Committee for allowing this recorded session, and especially to Professor Geert Mayfreud, who has kindly agreed to take questions on my behalf. I have no conflicts of interest to declare. For many years, clinicians have observed a link between the heart and the brain and vice versa. An increased incidence of transient cardiac dysfunction, myocardial injury, dynamic ECG changes, and an increased risk of arrhythmias have been observed in patients with acute stroke, especially strokes of the basal ganglia or the brainstem. And this concept of a crosstalk between the heart and the brain has been known for nearly a century, the most well-known phenomenon, of course, being the Cushing response to increased intracranial pressure. And today we know that there is a substantial crosstalk, not just between the brain and the heart, but between the brain and many other organs. This slide describes the pathophysiology of subarachnoid hemorrhage, illustrating its systemic effects. However, these phenomena are not specific to subarachnoid hemorrhage alone and may be seen in all types of brain injury. Central to this picture is the sympathetic nervous system activation with the catecholamine surge. A host of other changes may also occur, including cellular, humoral, and microcirculatory changes, microthrombosis, disruption of the blood-brain barrier, neuronal and endothelial cell death, all leading to systemic complications. In terms of the circulatory system, the clinical manifestations may be neurogenic pulmonary edema, circulatory instability, and shock. ECG changes may also occur, as do arrhythmias, cardiac arrest, and sudden cardiac death. There are specific areas in the brain that are particularly related to autonomic activity and the cardiovascular system. The insular cortex that is located deep at the base of the sylvian fissure plays a very vital role in controlling the sympathetic and parasympathetic tone. Laterality is a feature of this part of the brain, with the right hemisphere primarily controlling sympathetic activity, whereas the left controls parasympathetic activity. So this explains why patients with left-sided strokes tend to have more problems with hypertension and tachyarrhythmias, whereas those with right-sided lesions tend to suffer more from hypotension and bradycardia. Laterality is also illustrated intraoperatively, and those of you working with neuro anesthesia may have experienced this. Surgical manipulation of the left insular cortex tends to result in bradycardia and hypotension, whereas stimulation of the right insula causes tachycardia with a pressor effect. The brainstem, and more specifically the medulla oblongata, contains the cardiac, respiratory, and vasomotor centers, and any injury to this area will cause major difficulties in the control of these essential functions. The prefrontal and frontal cortex also appear to be important for the regulation of the autonomic nervous system balance. The prefrontal cortex contributes more to parasympathetic activity, and imbalances may be detected, for example, as changes in heart rate variability. The contribution of the hypothalamus to the autonomic nervous system function is already well known, and perhaps the most obvious illustration of this is the Cushing reflex, where an increased intracellular or intracranial pressure, causes an intense sympathetic activation, increasing the blood pressure. This will then trigger the baroreceptors for a reflex reduction in heart rate to the point of bradycardia and even asystole. Again, those of you involved in neuro anesthesia will be familiar with this, the tachyarrhythmias and hypertension that occur when the posterior hypothalamus is stimulated, such as during ventriculostomy or suprasellar procedures, and conversely the bradycardias that occur when the anterior hypothalamus is stimulated. Finally, just a quick word about the hippocampus. Although it is most well known for its role in memory, contains a very high concentration of glucocorticoid receptors, making it more vulnerable to long-term stress than most other brain areas, and may have implications for long-term cardiovascular morbidity. Given these pathophysiological mechanisms and anatomical relationships, it is therefore not surprising that cardiac manifestations of brain injury are common and can be severe. Elevated cardiac biomarkers are also closely related to the development of complications such as delayed cerebral ischemia. They may also be related to poor neurological outcomes both in the short and long term and mortality. And in fact, available data indicate that NT-proBNP in particular has an independent relationship with poor short and long-term cardiovascular and neurological outcomes. Arrhythmias are also very common, occurring almost universally among patients with subarachnoid hemorrhage, although deemed to be serious in about 5%. Ischemia-like ECG changes are common in all types of brain injury, and in subarachnoid hemorrhage have been reported to be present even 1 year after the event. Left ventricular systolic dysfunction occurs not uncommonly in about 1 in 5 patients, and the presence of a Takotsubo phenotype has been reported in up to 10% of patients with brain injury. Diastolic dysfunction has also been reported. The cardiovascular challenges that are particularly pertinent to intensive care that I want to highlight today are the arrhythmias and cardiac dysfunction, but for the sake of timekeeping, I will not discuss neurogenic pulmonary edema. Arrhythmias are common after all types of brain injury, particularly so after subarachnoid hemorrhage, where they have been reported to occur in 50 to 100% of all patients. They may be serious in 1 in 20 patients. There are significant associations with right-sided cortical activation in line with the sympathetic predominance of this side of the brain, and the involvement of the insular cortex seems to be particularly predisposing. So, for example, a large bleed from a right-sided MCA aneurysm would typically cause tachyarrhythmias. The most likely cause of these arrhythmias is an autonomic shift with a potentiated sympathetic response, although some studies show no correlation between levels of circulating catecholamines. This suggests that there may be other pathogenic mechanisms, for example, myocardial injury, that also occurs commonly in this group of patients. A wide variety of ECG changes may occur, and these may include ST to T segment changes, T-wave flattening or inversion, and QTC prolongation, as you see in this ECG here. ECG changes may be difficult to distinguish from acute coronary syndromes. They occur most commonly in the first few days after injury, and then they tend to resolve, although some may persist up to 1 year after the injury. So one option is to always obtain the ECG on admission and to repeat every 24 hours until resolution of the changes. Cardiac dysfunction occurs commonly in patients with all types of brain injury, although it has been best reported after subarachnoid hemorrhage, where its incidence is about 15%. Now, this is likely to be an underestimation because most neurological ICUs do not have regular echocardiography and biomarker surveillance, so it is plausible that a large proportion of mild injuries are missed. Left ventricular dysfunction has been described as sharing the same pathogenic mechanisms as other stress-related cardiomyopathies, including the classical Takotsubo syndrome. Systolic dysfunction usually occurs early, within 3 days of the insult, and is generally reversible. However, that does not mean that it doesn't contribute to significant mortality or morbidity. Left ventricular systolic dysfunction has generally been described as mild, although there is a wide spectrum of dysfunction. Both global and regional wall motion abnormalities have been seen. They tend to occur early, within 3 days of the brain injury. On the other hand, left ventricular diastolic dysfunction tends to occur later, about 5 days or more after subarachnoid hemorrhage, but they appear more commonly in 71 of patients in one prospective series. Diastolic dysfunction tends to be more related to age and premorbid hypertension. However, it was significantly associated with the development of pulmonary edema. So although the putative mechanism behind cardiac dysfunction and brain injury is this catecholamine surge, current data do not show a correlation with circulating catecholamine concentrations. So this suggests that there are also other pathogenic mechanisms. Neurogenic stress cardiomyopathy, detected using echocardiography, occurs in all types of brain injury and has been reported in 1 in 5 patients. Now, although the term neurogenic stress myopathy is often used interchangeably with Takotsubo syndrome, NSM is really a subset of Takotsubo syndrome where the trigger is neurological and clearly identifiable. So in fact, the presence of a neurological trigger is an independent risk factor for mortality in this syndrome. Cardiovascular complications are the second most common complication in brain-injured patients, and it carries with it not just a substantial mortality but morbidity also in the long term. Therefore, although cardiac dysfunction in brain injury is often described as transient, they are highly significant. Long-term cardiovascular outcomes and mortality are increased markedly among brain-injured patients with cardiovascular complications. However, what is unclear is whether or not NSM, or neurogenic stress myopathy, is in itself independently associated with these poor long-term outcomes, or whether it's simply an epiphenomenon reflecting the severity of brain injury. So in contrast to previous definitions where Takotsubo syndrome could only be diagnosed in the presence of psychological stress, the new INTERTAC definition of Takotsubo syndrome recognizes neurogenic causes as a trigger. Notably, the presence of significant coronary artery disease is no longer a contradiction. Although neurogenic stress myopathy shares many clinical and pathological features with classical emotional stress or psychological stress-induced Takotsubo syndrome, there are some important characteristics that differ. The pattern in Takotsubo syndrome is typically described as apical ballooning, resembling this Japanese octopus pot. However, in neurogenic stress myopathy, the typical segments that are involved are the basal and middle portions, with relative sparing of the apex. Nevertheless, neurogenic stress myopathy shares many other common features associated with the other stress-related cardiomyopathies, including the transiency of systolic dysfunction, the associated ECG changes, and increases in biomarker levels. It may be difficult on the ECG and using biomarkers alone to differentiate between acute coronary syndromes and neurogenic stress myopathy. Although differentiation between the acute coronary syndromes and neurogenic stress myopathy is generally by exclusion, there may be some helpful features. For example, NSM is suggested if the patient has no past cardiovascular morbidity. If there is a temporal relationship that can be clearly defined between the neurological insult and the cardiac dysfunction, this also suggests NSM. Further, wall motion abnormalities that cover more than one coronary artery territory, or inconsistency between the ECG and the echocardiographic findings. So wall motion abnormalities that do not really match the ECG also suggest NSM rather than acute coronary syndrome. And finally, inconsistency between the LVEF and cardiac troponin levels. So a disproportionately reduced LVEF for a given level of cardiac troponins also suggests neurogenic stress myopathy rather than an acute coronary syndrome. The mainstay of therapy once diagnosis has been established is to maintain normal volemia, as hypovolemia may induce an LVOT obstruction. Supportive therapy with a very judicious use of fluids and vasopressors, but even inotropes may be considered. In the presence of left ventricular outflow tract obstruction, inotropes should be used very cautiously because this may precipitate a total circulatory shutdown. And in these situations, beta blockade may be considered. Levosimendan may also be considered as a non-adrenergic inotrope, but beware that even this drug may precipitate left ventricular outflow tract obstruction and will require concurrent doses of vasopressors that may cancel out any of its advantages. It also has a very long half-life. In pulmonary edema, one would generally treat this as a systolic heart failure. Once again, consider using beta blockers and mechanical ventilation to reduce the myocardial wall tension and oxygen consumption. However, none of these therapies are evidence-based. Despite the cardiovascular system being so inextricably linked to the brain, and despite its importance for neurological outcomes, there is a huge heterogeneity in the management of brain injury in terms of cardiovascular management. And that includes haemodynamic targets, blood pressure control, and haemodynamic monitoring. And this was recently shown in this ESICM survey that perhaps many of you provided data for. Routine echocardiography was used in about 1/3 of all patients. Cardiac output monitoring was used in less than 20%, and advanced hemodynamic monitoring was used in a minority, about 10%. Given this lack of evidence, it is therefore not surprising that the choice of hemodynamic monitoring varies from unit to unit. And given the considerations that I've spoken about today, one approach may be to take a 12-lead ECG on admission and then daily until normalization of the ECG changes. I would advocate 5-lead ECGs for continuous monitoring since arrhythmias are so common. Invasive arterial blood pressure monitoring would be useful, not just for setting targets, but to titrate therapy according to institutional routines. I would also advocate using a transthoracic echocardiogram on admission and then repeat it often. Remember that systolic function develops early, whereas diastolic dysfunction develops later after day 5, and diastolic dysfunction is highly predictive of neurogenic pulmonary edema. Transpulmonary thermodilation may help guide fluid therapy and help assess volemic status, keeping, of course, in mind that dynamic indices are less useful in arrhythmias. The cardiac biomarkers, NT-proBNP and cardiac troponins on admission would be important for prognostic reasons. And then finally, heart rate variability may be prognostic of poorer outcomes in subarachnoid hemorrhage. However, this is still experimental. So despite the cardiovascular system being so inextricably linked to the brain, and despite its importance for neurological outcomes, there is still no consensus on how to best monitor these patients. And this is a subject of an ongoing ESICM consensus. So with that, I'd like to thank you very much for listening, and I'd like to open the lecture for questions.